Hey guys, this week we were covering a lot in our video, so I'm just going to jump right in. The research question that I had, or the problem that I'm trying to address, is does treating obstructive sleep apnea decrease cardiovascular events? And then we were asked to state if what literature around that topic, what it says. Literature around this topic is not always agreed upon. Some sources say yes, that because hypertension is a contributing factor to obstructive sleep apnea, then treating obstructive sleep apnea will decrease cardiovascular events. And then there are some contrary evidence that says no. Over time, there were no significant decreases in cardiovascular events, regardless of whether patients were compliant with their CPAP therapy or not. My hypotheses were, the first one was that the treatment of obstructive sleep apnea among patients with hypertension negatively affects or reduces cardiovascular events. And then my second hypothesis was the treatment of obstructive sleep apnea among patients with hypertension positively affects the patient's quality of life, meaning it increases their quality of life. And then I had a third hypothesis that read the treatment of obstructive sleep apnea among patients with hypertension decreases the burden of national expense. So by treating it, it would decrease the burden of cost. After feedback from Ollie, I've decided to drop this hypothesis, the third one, because, as he pointed out, I would need to derive these numbers from some sort of national database, something that would be unavailable to me in the forms of questionnaires, surveys, or medical records. There's no way to gather that data. And two, it's long-term data. I would have to wait until time had passed if I wanted to just test the certain people I want to do the chart reviews on and the questionnaires. So as far as the research design goes, that topic, decreasing the burden of national expense, does not align with the methodology of my data collection. So I cannot measure overall expenditures from questionnaires and retrospective chart reviews. So I have, in essence, I've created a population mismatch with this third hypothesis. So I have decided to just drop it. So we have two hypotheses now. Working forward from there, my research method, study design, and data collection. To answer that, I may have gotten a little ahead of myself in the last video because I feel like I answered that question. So I'll just clarify what I went over then. So for my research methodology, I will be using primary and secondary research. Primary research is through retrospective chart review, and I have access to that through a lab that I work in. And then some secondary resources would include other scientific papers on the subject, articles, and existing statistics. I would do some subjective questionnaires, and they provide a score about personal sleep and its effect on daily life. I feel like the response rate to that, I had originally said 100% because they are completed in office, and I got some feedback from that from well, I'll get to that in just a minute. I will also use questionnaires. They are the Epworth Sleepiness Scale and the Stop Bang Score. And then I would use data sets from the CDC's National Cardiovascular Disease Surveillance System. And I could use records, like I said, medical records from the sleep lab I work in Mississippi. My data collection would include patients who meet the definition of compliance, for one, and this definition would be what CMS uses, meaning the CPAP usage has to occur and be recorded for 4 hours or more per night for 70% of the time. And then I would also determine which ones had used CPAP for over 3 months. So I need their usage to exceed 3 months. That way they could become compliant. Acclimate to having the machine on, the mask on, and their body could acclimate to the pressure usage. So also I would have a list of the antihypertensive medications per patient. I would have that listed that my participants are aged 18 to 90, so only adult participants. Other data I would gather: BMI recorded, all genders, races would be categorized as Caucasian, Black, Spanish, and other. Other comorbidities of the participants would be listed, and except heart failure. Blood pressure readings from all participants before and after CPAP usage to determine effective usage on cardiac function. The number of ER and physician office visits related to cardiac symptoms before and after CPAP usage. Determine its effect, to help determine the effect of therapy on cardiac events. The Epworth Sleepiness Scale and the Stop Bang Score. Results of these questionnaires will determine if there's been an improvement in quality of life, because these are subjective questions. And we already know improved sleep and decreased sleep deprivation improves quality of life. And then some exclusions would be, of course, anyone aged less than 18 or over 90, or any chart reviews that did not have a gender listed, specific gender, and then those patients who already have heart failure. And then anyone non-compliant, meaning they're using their CPAP for less than 70% of the time, less than 4 hours per night. And those are the criteria I would use to build my data sets. Now, I did have some feedback from peers, so I've made a few changes to those. I believe it was Becky mentioned in her critique that relying on 100% feedback through questionnaires may not be possible. I think she may be right. So I'm maybe setting myself up for failure from the front if I look for that 100% of anything, really. So I've decided to take a more realistic approach and aim for an 85% response rate. Additionally, Tiger, I think, mentioned that I may be overwhelming myself with too much data. I decided to limit my data search based on that to my data search through medical records, my retrospective chart review, to a 6-month period. Still remaining 3 months post-therapy usage, but just a 6-month period of chart review. And Tiger also asked if I had a plan to redact PHI. Fortunately, the physician I work for is still using paper charts as a backup, so I will be able to just black out any patient identifiers. With the data gathered based on all the criteria mentioned above. I'm confident that I will have the necessary information, data to either support or contradict my hypotheses. I look forward to sharing more as we move along. Thanks.